Don't have a whole lot to report. We are working on the water line, trying to get through with the city, get through their conservation easement to get our irrigation water over to the hospital. We do have a new board member, or board person interested in being a board member.
On the SHS board?
No, on the MPC board. Sorry.
We need to talk to him, man.
Yeah, so he's gonna be at the next meeting, hopefully we'll be able to fill that spot.
Who is it again?
Brandon Johnson.
Oh, from NBIC.
From NBIC.
Oh, good,
Yep.
okay.
Yeah.
All right.
I don't think I have a whole lot more to report. Sales tax revenue's been good from what I can see so far. Other than that, we're just kind of in limbo. If anybody has any questions for me or?
I don't call it limbo, we call it moving forward.
Moving
Yeah,
forward.
Yeah.
Okay.
Well, yeah, appreciate the help with, the new RTU unit, some of it there.
Yeah,
That turned out well.
yeah, it looks like that turned over.
I think there's some software glitches that you were aware of.
Yeah.
But, that was taken care of. Okay.
That's about all I have. I don't know if anybody has any questions for me or
No, I think,
comments.
the facilities, we can talk a little bit about facilities later, but, I think Cody can handle that.
Yeah, yeah.
Not much to say. Okay, any questions? All right.
No.
All right, well, thanks, Dean.
All right.
Appreciate it.
Get out of here.
Next time, just call in, Dane.
Yeah, I know.
Yeah, I got your temperature checked.
Yeah,
It's always-
Yeah, I'm COVID free.
Can you spend your screen?
Full free healthcare.
Later, bud. Good seeing you, man.
Bridget, anybody on that?
We have someone watching, no comment.
Okay, do we have Todd Beasley on yet?
We have Dave on.
Is Dave Coford on? Okay.
He is. It is
All right.
Sharon. Yes.
Dave, it's all yours.
Yes.
Great, can you hear me okay?
Yes.
Yeah, actually.
Dave, give us just, we gotta get your presentation on the board.
Everyone has it in their packet.
You want me to give you a second to get that pulled up?
Yes, please.
Yes, sir.
Yeah, we'll let you know.
So Brandon Johnson is an employee, by the way.
Here? I was like, the name sounds super familiar.
Oh, I thought he was with Mountain Valley Irrigation.
Well, he is full-time. He's a relief EMT.
That's
Okay,
where I know
that's
the
where
name
I
from. I was like,
see it.
man, I know the
Yeah.
name.
Okay.
Another posting employees of the
Yeah, well, that worked.
He's a Lovett fan. That's who.
Oh, so that's a chemo, attorney, Steve. Okay.
Then.
I didn't-
We're almost there, Dave.
Okay.
That was comfort here. That's what it was. Looking like.
Oh, there you go, yeah.
I think came up.
That's been a successful business.
I like the direction.
Don't worry about that.
Oh,
Yeah. I mean, it looked like something done in the church. I wouldn't be surprised if it's commercial. Fire.
up to Westport?
Right off, yeah.
Oh, Westport, not the West.
Well, but I think it was still, like, I thought it was Dolores. But they had like the.
Sure you got the right age, Steve.
Yes.
6 or 7.
And actually, all of them, the Cristo Ranch. That's the Cristo,
Is that this one?
that's part of Duncan.
Right now, probably.
It's in the.
No, this is just the market, like, they sold the family property, yeah.
Okay, we're talking.
Page.
But it went under market, like, immediately, it went down there.
Yeah, you can put it on that screen.
You find it? Okay.
There you go.
Thank you.
Do you get any certification?
Okay, Dave, you're good to go.
Great.
Emoji.
All right, well, thank you for your time tonight. It'll take just a few minutes of your time. Just to introduce myself, my name is Dave Cofer. I'm the Vice President of Health Plan Contracting for CHC. And what I'd like to talk about tonight is what I hope will be a revenue opportunity for the hospital. It's called the VA Community Care Network. And if we flip over one slide, you'll see the logo for the U.S. Department of Veterans Affairs. So we're talking about the Veterans Administration and vets that receive their care through the VA medical system. So these are veterans who have a service-related condition or an injury, not to be confused with TRICARE, which is the health plan for active duty and retired military and their families. So that's just a regular old health plan. But if you're a vet and you have some condition that's related to your service in the military, then you are eligible to go to the VA medical system and get your care there. And so there's been a recent change in that, and that's what we're going to talk about tonight. Let's go ahead and flip over one more slide, and I'll give you a quick history on how we got to where we are today. As you will recall, maybe 8 to 10 years ago, the VA health system became a big political issue. There was quite an outrage amongst the people regarding the treatment of the vets and that the long wait times that the vets had to endure at the VA medical system and the care that they were receiving. So Congress got that message, and in 2014, they allocated $16 billion to try to improve the situation. And it was called the VA Choice Act. And it did two things. One, it pumped some money into the VA medical system so that they could hire more providers, more practitioners, in the hopes of bringing wait times down. And then two, it also created the Patient-Centered Community Care Network, or PC3, which was, okay, if they can't get care in the VA medical system, let's allow the vets to go outside that system under certain conditions to get that care. So fast forward 4 years from that to 2018, a new administration comes in. People are still feeling that the VA health system was not improving fast enough. So Congress acted again, and they created the VA Mission Act that replaced the Choice Act, and it created the Community Care Network. And the emphasis on this legislation was to allow even greater access of veterans to go outside of the VA health system to get their care in their communities. And that's called the VA Community Care Network, or VA-CCN. So let's go ahead and flip over one slide, and I have a comparison there between the old and the new, the old PC3 and the new CCN. So under PC3, it was really physician focused. It was really trying to get vets the ability to go to see a primary care physician or a specialty physician in their community. It wasn't so much emphasizing hospital care, although you could get those authorizations, but it was really more focused on outpatient physician care. CCN, however, emphasizes not only the physician care, but hospital care, and a greater emphasis on telehealth as well. Under PC3, it was very restrictive. It was difficult to get an authorization to go outside of the system, so there weren't a whole lot of those. That was centrally administered through TriWest. So it was a third party that was making those calls on whether you could get your authorization to go outside the VA health system. And with CCN, it's much less restrictive. And we're going to go over that in just a little bit, but it's much more flexible for the vets to go outside the system now under CCN. The payment under both the old and the new is still 100% of Medicare. And as I mentioned, PC3, the old one, was administered by TriWest, and the new one, CCN, is administered both by Optum and TriWest. And let's go ahead and flip over one slide. And you'll see a map of the United States, and the U.S. has been divvied up into 6 different regions. And you'll notice regions 1, 2, and 3, which is the Northeast, the central United States, and the Southeast, are all administered through Optum. Now, Optum may not be a name that you recognize, but you probably will recognize United Healthcare. Optum is a wholly owned subsidiary of United Healthcare. So basically, we're talking about United Healthcare here. TriWest, the administrator of the old program, has Texas and all the western states, including Colorado. So they kept about half of it. Whereas Optum is owned by United Healthcare, TriWest is a joint venture. It's been around for a couple of decades now. It's a joint venture between Blue Cross Blue Shield and University Health System. All right, let's flip over one more page, one more slide, and talk about how it is a vet can get an authorization, how that's different. These first two bullet points you'll see that hasn't changed under the old program or the new. If the service wasn't available at your local VA medical center, you could get an authorization and get it in your community. Or if the service fell outside of a certain distance requirements, drive time standards, or appointment availability standards, you could qualify to go outside the VA health system, get care in your community. That hasn't changed under the new system. What has changed is
Quick question, Dave.
Sure.
Dave, we have a quick question.
So that VA service area, Grand Junction, I think, is probably the closest
Albuquerque.
in Albuquerque.
It's either or is where all of our vets go.
So does this authorization allow people to stay local and not have to drive all the way up to Junction or down to Albuquerque?
Yeah, the distance requirement is 25 miles and the drive time is anything greater than 40 minutes.
Okay.
So yeah, you're good.
Yeah, that's.
But in
That's
addition
okay.
to that, so they've added two more criteria that you can qualify for, is if the available care at the VA Med Center doesn't meet quality standards, or if it's just simply determined to be in the best interest of the veteran to stay in his community to get the care, they can do that. And the other big change with this is under the old system, this authorization decision was made by 1-800, the answer is no, right? It was a third party, you're calling somebody trying to get an approval. Under this new system, this is physician to physician, practitioner to practitioner. It is the provider at the VA Med Center that gives that authorization and communicates that directly with the provider in the community. So it's much better. And I think they're going to be much more inclined to give authorizations because if you think about it, these providers at the VA Med Center, they've got wait times literally out for months. They're going to have a huge incentive to offload that wait time and get people care and give these authorizations. So I think that's going to loosen up these authorizations quite a bit. All right, let's flip over one page. So this all sounds great, but is the hospital contracted? The answer is yes. We signed an agreement last month. It's effective. TriWest was to have this rolled out in the spring, but COVID happened, so it's been delayed. They now say that actually today is the rollout day or the final day of the old program, and tomorrow is the new. So it is effective. It's in effect. We're contracted. We're ready to go. As I mentioned, the reimbursement is at 100% of Medicare. But in that contract, we have a payment clause that TriWest will pay us within 30 days of us submitting a claim to them. This is important because historically, the VA Med Center has been notorious for slow paying. And I'm not talking months, I'm talking about sometimes years. So this is very important that we have this clause in there that we get the payment if we're going to see these patients. And then finally, if this thing really goes south, it doesn't work out, we have a no-cause termination and we can get out of the agreement without cause at any time, just giving 90 days advance notice. So in summary, I think this may be an opportunity for the hospital and its providers to see more of these vets that are in your community, give them more care. And also, obviously, that brings in more business to the hospital. The downside that we found so far in the whole that gums up the works is that the vets themselves really aren't getting a lot of information from the VA about this. They're not really being told that they have a lot more flexibility than they've ever had historically to get care in their own community. So there may be an opportunity there to try to market to them. It can be difficult because there's not a database of all the vets that live in every zip code, right? That might have a service-related injury. That's not a public database, but you know, the VFW, or maybe there's some other sites and locations and billboards, those kinds of things that can get that word out. And then if your providers know that they can get those authorizations, then that might help get those patients in and keep them in your community so they're not having to drive away for their care.
Dave, is there ability to partner with the bigger facilities in Albuquerque and Junction to try to keep local patients local?
I missed the first part of that question.
Is there the possibility to kind of market and, you know, have conversations with Grand Junction and Albuquerque to keep our local vets local? Maybe they could help.
Yeah, I mean, on the VA end, yeah, cooperate and working with them on the VA end. I don't see why not, because, you know, those medical centers has a CEO or a director, and say, you know, we're here, we're ready to provide this, you know, here's our list of physicians, here we can talk, you know, here's the people we would talk to, that kind of thing, and establish that communication with them, make that easier. I don't see why not, yeah.
Okay.
And we also have a very active VA officer or office in Cortez too.
Great.
We work with them
Okay,
and PFS on a regular basis.
Cool.
great. Well, then you guys have it covered.
Great. Any other questions I can answer?
No,
We're good.
we're good. Yep.
Okay. Well, thank you again for your time this evening. Have a great evening.
Thanks, David. You have a good evening too. Appreciate it.
All right. Bye now.
All right. Todd, you on?
Double check.
I texted him, but I haven't seen him.
You didn't get the message. Yeah. So we all text him. Okay. No word?
No. Not that I know.
Okay, on to quality.
All right, so this is our CHC report. Their fiscal year ends in June, and so this is the whole last year that you'll see from June of last year to June of this year. And so we'll start down under quality because the operation metrics Rick covers in his report. So the first part is the process reports, and you can see severe sepsis is something that we're still working on. We were at 30%, and we do have a low number. We have implemented some new tactics that we're using to make sure that we meet that metric. And then if you go on down, our next one that we really see that we needed to work on was falls. Now, falls are measured on inpatients, so it's the number of inpatient falls compared to your patient days, and so that's where you get the 7.41. We would like to be below 3%. Now, during this quarter, we did have 6 falls. One person accounted for 4 of them. And remember, last month, we approved our new falls program called the SAFE program. So we are implementing that, and we hope to see a reduction in the falls from that specifically.
Of those 4, the person that had the 4 falls, were our measures and policy sufficient to have addressed that, or?
They were, and we even got a sitter to sit with her at some point, and she was very impulsive, so it was just hard to maintain that safety net for her. HCAPS, like I said, we are implementing new processes for that. We did see a dip during the COVID time, was not surprised by that. Even CMS does not require us to report during that time, or any hospitals that didn't want to. So our new whiteboards will be in by the end of next month, and we'll be implementing that as well as some of the other tactics with it. So additional things, we have some approvals to do. One is wound care, and we're finishing up that piece as well. So we do have the new dynamic health, which we will use for our wound care policy. And then if you go into the next slide. So the next slide is our skin prevention program, and it's called SKIN, which is Service, Keep Moving, Incontinent Moisture, and Nutrition and Hydration. So this is what the nurse will use to help prevent skin injuries when a patient's admitted that has the potential to have a skin injury. And that is our new products. And then the next slide is the wound product selection guide. So if a patient comes in with a wound, this will guide the nurse on knowing what product to select to protect the wound while they're here in the facility. And we had a couple of samples that we passed around. And I think it's just a really good program so that we know exactly what to do. We're doing the same thing every time.
The previous slide had the different manufacturers.
Different products in there.
Mm-hmm. Different products that we
They're like
use.
a product line, and you pick one based on the wound itself.
But do we have to choose only from that product line?
That's what we're doing, just this product line. So if you go back one slide, yes.
Right, okay.
Because it reduces the decision-making. We know that if a patient needs to be moved, we don't like to drag the patient, so we use the slide sheets. And that helps us to position the patient correctly in the bed, as well as to protect them if they're incontinent. And then part of the program, too, is the Braden score, which is the score we use. Next slide. And so this will guide them to know what scale they're on and then how to select products as well. And then the last slide is the slide that shows where we can have the most force that's applied to skin that can cause breakdown. So we would like to get approval for our wound program, and that will conclude our report for quality.
Who is head of wound care?
Yeah.
So currently Wendy is the wound person in the clinic. She's taken over the wound program. And that was one of the reasons we wanted to implement this as well internally for the inpatient side.
Okay. Thanks for asking that question.
Sure.
Yep, we need to make a motion to approve the pressure ulcer prevention policy and appendices.
I will make a motion to approve.
All right, all those in favor? Any opposed? Okay. All right,
Thank you.
thank you. Okay. Can we go back to Todd? Any word? Todd?
Mm-hmm.
No. Okay. All right, well, let's then go on to Rick. Okay,
Yeah, that makes sense.
yep,
Okay.
yep.
Hitting the financials. First of all, guys, is there any questions, any questions before we kind of hit the financial presentation?
None.
Okay. As we presented on Thursday, again, strong cash collections for August, $4.7 million. We did see a slight decrease in operating cash. And we also got our foundation donation for our BD Max machine. There will be an additional submission to the foundation, which will cover some of the tests that we ran. We're just waiting on a donation update from the foundation, so we can submit them to documentation. We didn't really have that big of a market gain for our investment accounts. And again, August was probably one of the strongest months we've ever seen. So we did about $11.4 million in gross revenues, which yielded an increase in our gross AR by about $700,000, and an increase in net of $237,000. Inventory was pretty much a wash. It was a push. Prepaid expenses, the same thing. If you guys will remember, in July, we had a lot of our policies, that's our renewal period, for a lot of our insurance-related policies, for property and casualty, D&O, and things like that. Fixed assets, again, we had a few assets that we brought into play. And then we had a fixed asset decrease primarily due to depreciation, which our depreciation was about $370,000. One of the assets that we're pretty excited about that we got in the month of September was our UV cleaning machine. So we can hit some contagious areas where patient has been diagnosed with COVID. So we can go in and we can hit it with some UV light that'll kill the disease on the surfaces. And then we can properly clean the area with either housekeeping or other personnel.
Hey, Rick.
Yes, sir.
How big is that?
Kind of about as big as maybe a copier.
Yeah, there's 2 towers. They're about this big around and about this tall,
So,
and they're connected.
Wheel around.
Mhm.
Wheel around.
So probably about 4 feet tall, about the size of a big copier, for lack of a better explanation.
So something I can't get for my house?
Probably not.
You know the right
Those
people.
little Zumba things, those will do it too.
Okay.
This machine was like $67,000.
Oh,
Yeah, so you
So
It doesn't do windows either.
well, if it doesn't. Sorry.
So we can deploy this to surgery, we can deploy it to our MOB, we can deploy it to our emergency department phase, our patient rooms, and ICU or med surg. So that was something that we took a look at. Positive, we had revenue over expense in August, 32,000, year-to-date, 805. And our earnings before interest, depreciation, and amortization for August was $550,000. And year-to-date earnings before interest, depreciation, and amortization approved to about $4.88 million. Again, all of our expenses were in line. And August of 2020 was a better month than August of 2019. So maybe we're in our final level of Jumanji. So any questions on the income statement or balance sheet? And not the Rob Jumanji, the Robin Williams.
Okay, good, yeah.
Okay.
Yeah, it's better reference.
All right,
Yeah, got it.
good.
Basically, we've paid about $2.4 million in our debt payments. MCHD with the sales tax was slightly over $1 million, and we paid about $2.4 million. John, specifically, we're hitting our ratios. Our August days cash on hand was 105. So again, we're doing well. Our goal for 12/31 is to be at 60 days. So we'll hit that, no problem. Statistically speaking, again, the volume increases in our clinic visits, surgeries, things like that. So, and we were only about 18 patient days short. So that was strong for a month. Our cash flow, and that shows on page 12, shows where we spent our cash, out to 105 days. And then our business office metric spreadsheet, again, our net days for our hospital AR is 39, 37 in the clinics, and we're pretty much zip along on our metrics except for commercial insurance, and that's because we still have a couple of appeals pending, and we got our credit balances down 50%, so we're tracking along there. Don't know if you guys have any additional questions on the financials, but we'll be happy to answer that.
John, did you have any?
John, you're on mute.
You're on mute, John.
That sounds really good. I was really brilliant. Now I'll just stumble over my words. No, they look very good and I appreciate it. I have no questions.
Yeah, thank you.
Maybe you can elaborate a little bit on the email that you and I had with Rick, or with Paul, the A's about the forgiveness, where we got.
Oh, sure. Yeah, so today we had lunch with, Paul DeHaze and Daniel Moser. Daniel's our new trust guy.
You had lunch. Yeah.
All right, okay. So Tony and I did.
Okay, how was, yeah.
Tony and I did. So, we had lunch with them and, we discussed the, payroll protection plan loan. And it is cleared the hurdle that is, vector up Zion's Bank. So it is now in a holding queue at SBA. What Paul told us is SBA hasn't done anything, they haven't processed anything with, forgiveness for any bank, not just Zion's Vector. So per the legislation, as we understand it, they've got 90 days to decide on it. But if it clears Vector, it's the first hurdle, and we should have total forgiveness, and it should turn into a grant technically in 90 days, which would be on or around December 30th. Will that happen? It should turn into a grant, yes. What's the delay with the SBA? I have no idea.
Okay.
No idea, but we did discuss that. The other thing, and Dan Moser has been on our account executives for our trust and our investments. He would like to see if we can, if he can meet you guys safely in person at maybe our December, board meeting. So he'd like to come in here and see if you guys had any questions. And we reviewed our investment strategies. Everything's conservative. We've got some pretty decent yields. We did take a punch in the mouth in April, but things the market has bounced back. So I think everybody took a punch in the mouth in April, but it has bounced back. So that was our discussion with those guys. CHC has given us some guidance on pursuing things with stimulus money. So it looks like, the majority, 90%, if not all those funds should be, turned into grants.
And then too early to know what's gonna go on with that additional bill coming out of Congress or not, or
Yeah.
languishing, I should say.
We get some legislative updates that I try to forward to you guys. I send it to Tom, one, because he's the chairman on the board, but most notably is because Tom did sign those documents. So, and we're trying to, decrease Tom's stress level of stress.
Thank you.
So as soon as we have updates, and we try to, we let you know what we know.
I do appreciate it.
Like I said, we cleared the first hurdle. We do have a PPP of over $2 million. PricewaterhouseCoopers will do a separate audit at the bank's expense or SBA's expense, probably in Q2, maybe Q3 of 2021. So that's the way it looks. New Congress takes sworn in early January, so anybody's crystal ball is good.
Any new information on cost report, our previous cost reports that were being reopened and?
For Medicaid reversals?
The Medicaid ones? Okay, so basically to get the Medicaid cost reports re-examined, we have sent letters to Novitas. So you can't open a Medicaid cost report without opening a Medicare cost report on intermediary to Novitas. We are waiting on finalization of the 16th, 17th, and 18th, and the 15th. And then we'll have BKD do some work with that. So that's the update. And our friends at Novitas can take up to a few years to review and do settlement. So what I can tell you is we get a weekly distribution from Medicaid every Thursday. We're having 30,000 withheld. So we probably owe Medicaid in the neighborhood of $3 million. So if we don't see any forgiveness or any recalculation of that, we'll have Medicaid paid off through some of the grant balances that we have, as well as the Medicaid cost reports of $2.2 million by, I would say, October, November of 2022. And we did have a lot of Medicaid credit balances due to the fact that under previous administrations before we got here, it was discussed that the reason that the hospital was having financial issues is because Medicaid wasn't paying us, which wasn't entirely actual. So what they did is they rebuilt things 2 and 3 times, so we had credit balance to show up in addition to the cost report. Reviews that they had that showed we owe about $2.2 million.
That whiteboard lesson you gave us past year was.
Yes, sir.
Was informative.
Yeah, that was almost 2 years ago.
And the cat analogy was really,
Yes.
still remember that.
Okay, don't go there again.
Do you remember the?
Oh, yeah, I remember the cat.
Yeah.
I blocked that.
No.
If you don't know, Shirley, I'll use it.
Susan, you're glad you missed that.
Yeah.
I missed that.
I'll fill you in.
Yeah.
Karen talked about Karen can show you lots of wounds, so you have a nice experience.
I think I'll pass on that one.
Yeah, good choice, yeah.
Really good now.
So, thanks, Rick, as usual, great job, man.
Thank you.
Thank you. Yeah,
Strong work.
Knocked it out of the park.
For your time, can you just say EBITDA for us? I didn't hear that.
Gary said.
Keep it out. What do you, you want me to say boiler? I'm no, sorry, wrong meeting.
Wrong one. Wrong one.
Okay. Anything else? So, Rick, did you have anything else at all? That's
No,
it?
sir, not at all.
Okay, we do need to make a motion to approve the August financials as recommended by the committee. Okay, is there a second?
Second.
Okay, all those in favor?
Aye.
Any opposed? Any questions about the CHC invoice? Okay, do need to make a motion to approve the CHC invoice as recommended by the finance committee.
So moved.
Okay, Shirley, is there a second?
Second.
Okay, Susan, all right, all those in favor?
Aye.
Any opposed? Okay.
Can you tell me who seconded? I'm sorry.
Susan seconded it, yeah.
Very softly.
All right,
Still thinking about the cat.
and I think, nothing from Todd, I guess, so we can move forward.
I think he had some extenuating circumstances.
Yep, okay, and let's move on to Carrie.
Hello, everyone. I apologize that I have not got my camera working here, so we'll have to take for this portion at least my verbal promise that I am here. I have a lot to update the board on this month. It's been a very busy month in recruiting and also transitioning several different pieces of the clinics together. So let's move forward with that. Sorry, just pulling up my slide. Bridget, I'm sorry I didn't send this to you. So the first thing that I'd like to discuss is recruiting. And currently we are recruiting for an OBGYN. We have several in the pipeline working with recruiting, working with recruiters to get those people onboarded as far as getting them scheduled for interviews and on-site visits. Now that we have a little bit more leeway to do that, we definitely have been working on that. We have 2 potentials that are in the pipeline, but no further information yet to share with the board. Now, with the second piece, I would like to talk about general surgery. We did have a general surgeon resident who interviewed with us 2 weeks ago. Her name is Dr. Lynn Bryan. She is interested in the position and we are continuing to pursue her. We have scheduled a time with her to make a decision. She is making a decision about where she will transition on October 15th. So we should have more information about Dr. Bryan at that time. Again, she's a resident coming out of residency. Dr. Madison has worked with her as far as communicating and an on-site interview. If that doesn't happen to work out, we do have 2 further general surgeons in the pipeline. Those are in the telephone interview process with Dr. Madison. Those will be completed next week, and we will move forward with those 2 husband and wife team of general surgeons if we don't have anything further from Dr. Bryan at that time. The next portion is wound care. We did complete the wound care transition last week. So from PT in the hospital, we have transitioned it to the clinics using Wendy Stevens. Wendy Stevens is a nurse practitioner that comes to us with wound care experience and experience as a hospitalist. We have begun that transition as of last week, and currently her schedule is full. And so we are looking to hire a RN to work with her to create that additional volume in the clinics and availability for patients. So that should be coming in the next few weeks. The last thing, we are still recruiting for an advanced practice provider. So that is somebody to work with Dr. Rasma. He has a very full schedule, and as everyone knows, he is booked for the next couple weeks. So I want to make, next couple months. So I want to make sure that we can get patients in and continue to see those patients. Again, we are still in the recruitment phase. We have somebody identified, but they have some further obligations, and we have some further vetting to do. So we will continue to do that. The next portion that I'd like to talk about is, are there any questions about recruitment?
No questions, Carrie.
Okay.
And Carrie, just to clarify, I think Kevin Madison was really, really impressed by the resident who interviewed, correct?
He was. Yep, absolutely. And, again, I think my role and the role of, our team and the board is that we are going to address this vacant position, but also address it in a way that we are absolutely sure and confident in the person that we choose. And so while Dr. Ryan has not made any decisions at this time, like I said, we are continuing to move forward and vet other potential general surgeons just to make sure that we are meeting the community need at this time.
Awesome.
Okay. So another piece that I'd like to talk about is the athletic trainers. We have begun our work with Cortez, Mancos, and Dolores schools to transition athletic trainers to our physical therapy program. So what that means for us as a community and also for our health system is that we will have athletic trainers working at the high schools in all the sports that are available. Obviously, there's a limited amount this year with COVID, but they will work for the hospital, for SHS, continuing to provide care and education to those students, thus increasing our availability to students and healthcare in the community. So that's been a huge win for us. We are very excited to bring the 2 athletic trainers that cover those 3 schools on. We look forward to welcoming additional schools such as Dove Creek in the future. Again, those are all preliminary discussions, but very, very important to the success of the healthcare access in our community for especially teens. Speaking of teens and school-based, we have school-based health that is currently up and running. They have been seeing patients and actually have been seeing more COVID tested patients than we expected, working very hard over there. Again, we have one provider over there, Teresa Brown Sanchez. She has been working with her team very diligently, as well as with the RE1 school district to ensure that any students that have symptoms are seen that day and tested if they choose to be tested immediately. Again, we are using those BD Max tests for any students that are symptomatic or teachers or staff in the RE1 school district, as well as any school district in Montezuma County. So very important service that we're providing. Oh, I'm sorry, go ahead.
Yeah, Carrie, it's Tom. So if we have a kid that comes in, or if the school has a kid that comes in complaining or symptomatic, we do that test. What's the protocol at the school? Are they quarantining that kid until the results are back?
Yes, they are.
Okay.
So, yep, absolutely. That's one of the protocols that we worked on with the health department as well as the school district. Specifically for Cortez, we have worked, because they are the larger school district, we've worked very close with collaboratively with them to develop their plan. We had a lot of clinical input from myself as well as Mark Meyer. And a huge thank you to Mark Meyer for participating and helping to guide us there. We did successfully, I believe, work, the three of us, with the health department, the Cortez School District, and SHS together to create a safe opening for schools. We have not seen that uptick, knock on wood, that was expected. So again, a huge win for our community in that way too. So I think what you'll see from the clinic side and also from SHS in general is more community outreach, community connections with the schools, developing those relationships that have long gone undeveloped. And so we are working very diligently to kind of create that bridge and make sure that we have the ability to provide healthcare to those that need it in the school districts, as well as teachers and staff.
Have we been reaching out to Mancos and Dolores districts at all to provide
Absolutely.
testing?
Yes, so they have the same exact option that the RE1 school district has. If they have a symptomatic student, they are to come through the drive-through. We will process that test in the BD Max, so it will be, within a 12-hour time period, you'll have a result. We are educating those students to stay home, to stay isolated and quarantine until that result is reported. And then obviously, if they're still experiencing symptoms, we're asking them not to return to school per protocol until those symptoms are gone, even if their test is negative. So there's a very specific protocol in place for all the school districts in our area to ensure that we provide a safe learning environment for all those that are attending school right now.
Well, I do know that our family, especially my daughter, who is tired of being grounded with me at home, is glad to be back in school. So you guys are doing a good job keeping
Absolutely.
school.
Absolutely. So the last point that I wanted to make was involving the COVID issues and dealing with COVID in the clinics and how we are managing that as an organization with the community. Again, we all know that we have this drive-through that we have been working with our providers as well as the EMS team to make this happen over the last 6 months. As that continues to develop, we as a clinic team decided that it was very important to be able to see people the same day if they were having COVID symptoms. So we have created an acute care clinic. So any one of our patients within SHS, if you have a primary care provider within the SHS SMG group, then you can call in if you have symptoms to get an appointment. You can have a same day appointment with the provider. You will be seen at the walk-in, and it's not a walk-in appointment. It's specifically with an appointment. So you call in, you're scheduled for 1 p.m. that day or a scheduled time slot. You are seen, tested if there are COVID symptoms. You are tested for COVID. We have the ability to do testing for flu and strep and all RSV and all the other things that potentially could cause those symptoms. But I think the most important thing to note is that we did stand up this acute care clinic last week so that all of our patients would have the ability to be seen if they were symptomatic immediately and access to testing. And knowing that, we have had great response from our providers. We had 4 of our APPs from our primary care clinic who have volunteered their time, even though they are a scheduled workday. They're not going to see their own patients. They're going to see the walk-in patients, which are the acute care patients, 4 appointments at the walk-in. So anyone that's having symptoms is being seen, tested, and addressed the same day. And again, that helps to keep healthy people in our building and those that are experiencing symptoms outside of our building, the main hospital building, as well as the MOB. We do have a specific protocol for that acute care clinic that involves a drive-up component where you call in and the provider comes out to the car. They do some assessing and they make a determination if you are safe enough or COVID symptom-free enough to be brought into the building, then they can bring you into the building and do a full assessment, or they make the determination at the car that, one, you need to go to the ER for further treatment, or two, we need to do a COVID test and send you home to quarantine. So this is a huge, has been a huge project on the primary care side that we have worked on for about a month and a half to get started, knowing that, you know, we do plan to see an uptick in COVID cases, an uptick in symptomatic people as people in Colorado start going inside because it's cold, more exposure risks. So again, just a way that we're kind of ahead of the ball here, and we are definitely working progressively to prevent sick people from coming in the main hospital and clinics.
Great job.
I think that's all that I have.
Any questions for Carrie? Okay.
Singleton.
Yes. And how are we, I know that BD Max manufacturers were transitioning, and so there was a shortage, not a shortage, but a delay in manufacturing.
Yes.
Not
So-
until November, it's when we get allocated back to what we were at $240 a week.
But we were buying up quite a bit, right?
We have stock.
Yes, we do have about 649 currently in-house, so we are a little bit ahead.
We're getting a little over half our allocation
Correct.
right now, so.
Per week.
So, yeah, it's not, it hasn't totally dried up, so.
Right, and then they'll pay us back in November everything that we missed out on in September and October. So
Quite a manufacturing timing.
Yeah, not good.
Yeah.
Well, they're trying to expand their factory
Yep.
so they can crank out more tests.
Oh, okay.
So,
Interesting. All right.
Tom,
Well,
I
thank
did
you,
have
Carrie.
one further, I'm sorry, I did have one further thing to report to the board. And that was our patient waiting list. As you know, that was one of the primary care targets set forth by myself and the team this year. We have eliminated the new patient wait list that we had at the beginning of the year, and we are currently servicing all the patients who have turned in a packet within 13 days. So they have patients that are new to our practice who are coming in, submitting a packet. They are seeing a provider within 13 days, which is a huge relief from where we were a year ago. Another piece to that is just to know that the amount of new patients that we're seeing every month, this past month, we took in 113 new patient packets, and they were processed and seen. So just another exciting thing to report to the board.
Right on. Good. Yeah. Good. Yeah. Keep people west of Durango. Yeah. I mean, it's nice over there, of course. Yeah.
Nice place to visit.
Terrible place.
Yeah. All right, well, thanks, Carrie. No more questions for Carrie from the board? All right.
Just strong work as always.
Yeah, wonderful. Look forward to having you here in person next time, but we understand.
Thank you.
Okay. All righty. On to Tony.
You know, just, not a whole lot in regular session. I got a few things in executive we need to discuss, but, you know, we're finalizing our 2021 business plan, and we'll have that ready for the board to review next month. We'll be reviewing it with CHC in the next couple of weeks, getting everything finalized, and we'll go over with the board to get that approved. But like I said, I think everything else we'll discuss in executive.
Okay. All right, no more questions for Tony? All right, it's 6:12, we're gonna adjourn from our regular session and go into executive. Do I hear a motion to adjourn?
Don?
We have a question? Yeah.
Yeah, John, you want to go ahead and approve your minutes?
Oh, that's right, thank you. Do I hear a motion to adjourn, I'm sorry, do I hear a motion to approve the regular session minutes from last month?
So moved.
Is there a second? Dan, okay, all those in favor?
Aye.
Opposed? Okay. All right, I guess we don't need a motion to adjourn to executive, we'll just go ahead and adjourn.
Let me just make sure we don't have any comments, give me one.
Oh, yeah. Thanks, John.
Thank you.
All right, so for those joining an exec, you have that separate link, right?
Yep. John, you know about that
Yeah.
separate link for?
I know about the secret link, so I'm off to find it.
All
Thank
right.
you.
Comment.
All right. Okay, we'll take a quick break here and, we'll get into an executive session here in a few minutes, so.